comparison between the conventional and the Sydney systems of reporting. This is the institute where I belong to. FNAC, as all of us know, is an established pre-therapeutic tool used in the evaluation of various palpable and deep cerebral mass. And the common organs subjected to FNAC are lymph nodes, thyroid, salivary gland, soft tissue, and intrathoracic and certain intra-abdominal organs. Lymph node FNAC is quite effective when it comes to diagnosing infective, inflammatory, and metastatic lesions, whereas it is diagnostically very challenging when it comes to hematolymphoid malignancies. And as all of us know, we have lots of reporting systems introduced in the cytology, which has improved the patient management by establishing a very good rapport between the patients and cytopathologists. The Sydney system for reporting cytopathology, lymph node cytopathology, was proposed in 2020. And the main aim of the Sydney system was to increase the reliability of lymph node FNAC and the clinician awareness of its diagnostic potential. The Sydney system, it's a two-tiered diagnostic system. In the step one, we try to provide a provisional diagnosis, at times even a definitive diagnosis, based mostly on cytomorphological basis and using certain special things. Whereas in the step two, diagnostically challenging cases are dealt with, and precise diagnosis in such cases is made with specialized ancillary tests like wider panel of immunocytochemical markers, cytometric evaluation, or molecular techniques. Some studies have assessed even the risk of malignancy by application of the proposed system for classification of reporting lymph node cytopathology, according to which the categories, the three categories, the category 3, 4, and 5, that is atypical category, suspicious category, and malignant categories have a higher risk of malignancy. The objective of our study was to assess the Sydney system of reporting lymph node cytopathology and to compare it with the conventional reporting system. And our objective was also to assess the advantages of the Sydney system with respect to diagnostic accuracy, with or without cytodiagnostic accuracy, with or without special stains and basic immunocytochemical markers, and also to assess the utility of specialized ancillary techniques in arriving at a precise diagnosis. It was a cross-sectional analytical study which was conducted over a period of 2 years in the Department of Pathology, JIPMER, Puducherry, India. There were two groups. The first group is the conventional group, which included 355 cases of archived lymph node FNACs, which were reported between 2019 and 20, and these cases, all of these cases had proper diagnostic follow-up. And the cases that were interpreted as non-diagnostic but having diagnostic follow-up were also included in the study. Similarly, the Sydney group had the fresh 355 fresh cases of lymph node FNACs that were reported during 2021 and 22 with subsequent diagnostic follow-up. The cases without diagnostic follow-up were excluded, and also the cases which did not have well-stained slides were also excluded from the study. The clinical data and the laboratory data was collected from all the cases included in the study. FNAC was done either by the guided technique or non-guided technique. A rapid on-site evaluation to check the adequacy of material was done in all our Sydney group of cases, while in most of the conventional group also it was done. While interpreting smears, a general evaluation was done initially, and whenever we suspected hematolymphoid neoplasm, an algorithmic approach was followed. The ancillary studies included special stains, like conventional special stains, cell blocks, immunocytochemistry performed on smears, immunohistochemistry performed on cell blocks, and flow cytometric evaluation. A comparative evaluation of both the systems was done, and the sensitivity, specificity, diagnostic accuracy, and predictive values were all done. The difference between the conventional and the Sydney system in our study was that the category 3 was somewhat better defined, and the use of rapid on-site evaluation was more regularized, and it was done in almost all the cases in Sydney's system. And the use of ancillary tests was also better streamlined in a stepwise manner. These are some examples of non-diagnostic aspects. The first case shows uh, benign bronchial epithelials in a so-called mediastinal lymph node. We cannot give any diagnosis in that. Cervical lymph node showing just hemorrhagic elements, axillary lymph node showing the adipose tissue fragments. Whenever we came across these kind of cases, they were all interpreted as non-diagnostic. And category 2 included the cases where we could give a definitive diagnosis like granulomatous lymphitis, tuberculous lymphitis, or specific organisms, or diseases like Rosai-Dorfman disease, etc. Category 3 included certain scenarios like uh, heterogeneous population of lymphoid cells, suggestive of reactive process, but a follicular lymphoma cannot be excluded. Similarly, whenever we came across large number of excessive number of blasts causing the confusion with high-grade lymphoma, or you may choose small lymphoid cells causing confusion with chronic lymphoproliferative disorders, or when the atypical cells were non-lymphoid but insufficient for a definitive opinion. In such cases, category 3 or L3 was given. In such cases, the Sydney system recommends repeat FNAC as a preferably with flow cytometric evaluation and cytogenetics. One can go for even core needle biopsy and excisional biopsy in such cases. This is one such case, an elderly patient presenting with generalized lymphadenopathy. Uh, Smears were spasticellular, showing some mature lymphocytes, occasional lymphoplasmacytoid cells, and some plasmacytes also. The material is insufficient for any definitive meaning, but they look typical. So, in such cases, we use the term ALUS, that is atypical lymphoid cells of uncertain significance. Category 4, here the malignant features are somewhat clear cut, but we need some ancillary tests to give a definitive diagnosis, like the small or medium-sized cell, atypical lymphoid cell, suspicious of lymphoma, but flow cytometric evaluation or immunocytochemical evaluation is not available. And a polymorphous population of cells with Reed-Sternberg or Reed-Sternberg-like cells, but basic ICC is not diagnostic. Or smears are scantily cellular, but whatever cells are there, they're showing evidence of either large cell lymphoma or Burkitt lymphoma. These are the cases where we call them L4. And even cases with atypical non-lymphoid cells suspicious of metastasis, but sufficient material is not available for a further evaluation. In such cases also, the Sydney system recommends the repeat definitive OPI material for further studies. So this is one such case. The clinical history is very much indicative of metastatic squamous cell carcinoma from the penis, but the aspirate shows predominantly reactive lymphoid cells. However, there are a few cells, keratinized cells, trapped within the blood clot, which is indicating that this is a metastatic squamous cell carcinoma, but quantitatively it is not sufficient. So in such cases, suspicious for malignancy with the better category. Similarly, polymorphous population of cell history is also very much indicative of Hodgkin's lymphoma. Polymorphous population of cells, including even a few lymphocytes. There are some degenerated RS-like cells, but immunocytochemical confirmation is not available. In such cases, we used to be suspicious for malignancy. Category 5, where the features are clear cut, both on morphological basis and with some basic immunomarkers, we can give even a definitive precise diagnosis itself. Whenever we had a suspicion of hematolymphatic malignancies, we used an algorithm of protection. This is how we take the lymph node aspect. We look for cellularity. If it is partially cellular, then also we did not ignore. Like it could be if there is clinical suspicion of lymphoma, could be a case of nodular sclerosis Hodgkin's lymphoma. So repeat FNAC in such cases is bad. And if it was non-diagnostic, even after that, a biopsy was sufficed. Whereas if it is cellular, then we look for whether it is a monomorphic population of small cells, medium cells, and large cells, or whether it's polymorphous population of cells comprising of mixed inflammatory cells or polymorphous lymphoid cells, or whether the cells are comprised of anaplastic morphology. Depending on that, so if it is a small lymphoid cell population, one of the chronic lymphoproliferative disorders like ZLL, SLL, lymphoplasmacytic lymphoma, marginal zone lymphoma, these things were considered. Whereas when it is monomorphic medium-sized cell, bucket lymphoma, plastic lymphomas were considered. Whereas when it was predominantly large cell, diffuse large B-cell lymphoma, and other high-grade lymphomas were considered. When it was a mixed inflammatory type of population, most commonly Hodgkin's lymphoma, but it can be sometimes even peripheral T-cell lymphoma and anaplastic large cell lymphoma. So this is the algorithm for monomorphic small cell population. So there are certain morphological clues for each of these chronic lymphoproliferative disorders like CLL, SLL, LPL, lymphoplasmacytic lymphoma, mantle cell lymphoma, marginal zone lymphoma, follicular lymphoma. Uh, and again, we need to look at the age of these patients. In patients, still, it could be lymphoma or it could be even reactive lymphoid hyperplasia. Medium size, again, age should be taken into consideration, and in age, possibility of bucket lymphoma and plastic lymphomas are more common, whereas in elderly patients, it is either blastoid lymphomas or any other high-grade lymphomas. And if it is predominantly large cell, the most common diagnosis, the most commonly encountered diagnosis is large B-cell lymphoma. But it included even other cases like high-grade follicular lymphomas, apical bucket lymphoma, plasmablastic lymphoma, etc. Polymorphous population, again, mixed cellularity Hodgkin's lymphoma, peripheral T-cell lymphoma, anaplastic large cell lymphoma, and sometimes even leukemic infiltrate. Pleomorphic cell population, we had to, apart from lymphomas, we had to even keep the possibilities of undifferentiated carcinomas, melanomas, lymphomas, Hodgkin's lymphoma, nodular sclerosis type of Hodgkin's lymphoma, syncytial variant. Accordingly, we had to go for the specialized studies like undifferentiated carcinoma resolved with cytokeratin, melanoma with HMB45, lymphoma with LC, and subsequently we had to distinguish from other lymphomas like anaplastic DLB cell or anaplastic large cell lymphoma or plasmablastic lymphoma. In such cases, clinical hematological workup and biopsy is essential. So these are some of the cases where the malignancies can have highly anaplastic and pleomorphic malignant cells, anaplastic large cell lymphoma, syncytial variant of nodular sclerosis Hodgkin's lymphoma, amelonotic melanoma, and metastatic carcinoma. Almost, if you see only this portion, it almost looks like lymphoma. So coming to our results, we had a total of 710 cases with 355 cases each in the conventional NCD group. Age, as per the age is concerned, most of the cases were reported in the 5th and 6th decades. And there was no particular sex predilection, and distribution by majority of the lymph nodes for cervical lymph nodes, followed by axillary and inguinal lymph nodes. And mode of efficacy performed was non-guided in most of the cases in both the systems. And this is a table showing the category-wise distribution of lymph node efficacy, the conventional versus Sydney group. We had significantly more number of benign lesions in the conventional group, whereas significantly more number of malignant cases in the Sydney group. And also a slight decrease in the non-diagnostic rate was observed in the Sydney group, probably because of the consistent use of rapid onset evaluation. Among the benign lesions, reactive lymphoid hyperplasia was the most prominent diagnosis, followed by tuberculosis. And In some of these cases, we had biopsy correlation also, and all were concordant. And there were no discordant biopsy, no cytohistological discordance. Whenever there was some discordance, it was because of the discrepancy in the site of aspiration and site of biopsy. And these are some of our reactive conditions. Like this is a aspirate from a patient who was in dialytic therapy, showing reactive spectrum of lymphoid cells, drug-induced lymphadenopathy, showing a preponderance of eosinophils. This is lymph node involvement, IgG4 related disease, showing increase in the plasma cells. As I said, tuberculosis was the next common benign lesion, and in some of these cases also there was biopsy correlation. Most of which were concordant. However, when there was discrepancy, it was because of the discrepancy in the site of aspiration and site of biopsy. We did even studies like gene expert studies, and that also contributed to diagnosis of tuberculosis in certain cases. Some of the pictures from our cases. This is a case of case-treating tuberculous granulomatous lymphadenitis, granuloma here, EFP positivity, negative images of the bacilli, and non-PCD epithelial cell granulomatous lesion. Other than the non-tuberculous benign lesions, the benign lesions other than non-tuberculous conditions were separating lymphadenitis, Kimura's disease, Kikuchi disease, or SLE lymphadenitis, which were encountered in both the conventional and the CT systems of report. This is just to highlight our workup impact. In all necrotic cases, necrotizing, but irrespective of whatever is the necrotic type, but we did the sudden stain and fast stain in order to rule out any infective pathology. So this is a case of this separative lymphadenitis. A classic case of Kikuchi's disease characterized by histocytic necrotizing pattern, where histocytes are also positive for myeloperoxidase. An atypical category. In fact, as compared to the study, various other studies in the literature, we had less number of atypical cases, both in the conventional group as well as in the Sydney group. Slightly more, it was slightly more in the Sydney group. This is one such case where this polymorphic exudative background showing an occasional keratinized type of lymph node, and it is very difficult to give a diagnosis in this, but we called it atypical squamous cells of undetermined significance, but it turned out to be a case of squamous cell carcinoma, metastatic squamous cell carcinoma. Similarly, this is a case of it's a case where the aspirate shows predominantly lymphocytes, but there are scattered large cells which don't fit into any of the reactive spectrum. So we called it the atypical lymphoid lesion of undetermined significance, and it turned out to be a case of T-cell histiocyte with large cell B-cell lymphoma, which was confirmed by histochemical evaluation also. And interestingly, this case had even the coexisting tuberculosis, which was missed out on FNAC due to sampling error. Category 4, suspicious of malignancy. We had more number of suspicious cases in the Sydney group. This is because of more rigid morphological application, and the reasons for increase in the number of L4 are suspicious cases is that they were sparsely cellular smears, but cells definitively indicative of malignancies like lymphoid, atypical lymphoid, or non-lymphoid, or leads converse cells. So sometimes it was all necrotic, but whatever few cells were present, they gave hint of some differentiated malignancy. And sometimes, occasional fragments trapped in the blood clot also gave uh, hint at the underlying diagnosis. So these are some of our cases. So this was a hemorrhagic aspirate showing a papillary cluster here, some of our bodies also. was not very cellular, but this particular structure itself is very much indicating that this is a metastatic papillary adenocarcinoma. Biopsy subsequently was confirmatory, but however, cellular was not really contributed in this case. And here, these are the only clusters which we picked up on FNA smears, which were all crushed out, but they were looking atypical and keratinized. We called it suspicious of malignancy with suggestion of squamous cell carcinoma. This turned out to be a metastatic squamous cell carcinoma. So, as I said, we were too rigid in calling it directly calling it malignancy, though we knew that this was a known case of invasive ductal carcinoma. Because of crush artifact, we called it suspicious, but this was a known case of breast carcinoma with the data of the immunohistochemistry carcinoma. This is an interesting case which was reported as suspicious of anaplastic large cell lymphoma on lymph node aspirate, but the biopsy was taken from the duodenal biopsy. The duodenal biopsy was consistent with lymphoma, but it was not consistent with anaplastic large cell lymphoma, but consistent with the diffuse large B-cell lymphoma. We couldn't explain this particular discrepancy. So most of our hematolymphoid malignancies in the conventional system had very good biopsy as well as correlation. And most of the hematolymphoid malignancies in the Sydney group also had very good correlation between level 1 and level 2 diagnosis, though we had diagnostic difficulties encountered in certain cases of marginal zone lymphoma, atypical CLL, follicular lymphoma, etc. Some of the pictures which I would like to share. Uh, there are certain morphological clues I said. This is a plum chromatic, which is described as a cellular squamous, which serves as a diagnostic clue to pick up CLL varicella, and there is promyelocytic differentiation also. Yeah. Not promyelocytic, pro-lymphocytic differentiation also here. So flow cytometry evaluation is confirmatory. Marginal zone lymphoma. Another case of marginal zone lymphoma, going by cytomorphological clues, we call it CLL varicella, but however, it turned out to be a case of marginal zone lymphoma on flow cytometric evaluation. This is a simple IHC algorithmic approach, which is very useful for distinguishing various chronic lymphoproliferative disorders. We use pan B-cell marker, CD5, CD23, CD cyclin D1, and CD11C, BCL2, and CD10. Medium-sized lymphomas, Burkitt lymphoma, characteristic morphology, flow cytometric evaluation, T lymphoblastic lymphoma, even clinical presentation also serves as clues to the diagnosis in such cases. Large cell lymphomas. So this is large cell lymphomas also we had certain clues, and the glaring lymphoglandular bodies were the clues which we encountered in majority of our diffuse large B-cell lymphoma cases. One can use even Hans algorithm, but we did not use it in on-cytologic material. So just to show these glaring lymphoglandular bodies and large atypical lymphoid cells. This is one other high-grade lymphoma, follicular lymphoma. You can see the nuclear cleavage. There are two cells showing nuclear cleavage, which is characteristic of follicular lymphoma. Peripheral T-cell lymphoma can have a varied morphology, and here it is showing polymorphous lymphoid population presenting mainly as large lymphoid malignancy, and Hodgkin's lymphoma, which I have already shown. And this is a case of lymphocyte depleted Hodgkin's type. There were more of RS cells, less of lymphocytes, and histology was concordant. But we did not call it lymphocyte depleted, but we call it Hodgkin's lymphoma. Subtyping sometimes is very difficult on cytology. And this is an interesting piece again. This kind of clustering can lead to misdiagnosis of epithelial malignancy, whereas the immunocytochemistry, basic immunocytochemical marker like leukocyte common antigen gave us a hint that this is a lymphoma. And this turned out to be a case of anaplastic large cell lymphoma. So malignancies with pleomorphism. non-hematologic lymphoid malignancies in the conventional group, as well as in the Sydney group, had very good biopsy correlation. Metastatic squamous cell carcinoma. This is the aspirate and this is the primary from the mucosa. Metastatic adenocarcinoma, aspirate, lymph node aspirate, and this is the ICC performed on CK7 ICC performed on smear. Metastatic small cell carcinoma, very clear cut morphology. The morphology itself is very much diagnostic, but we can go for markers like synaptophysin and chromophore. Metastatic papillary carcinoma, very clear cut impact actually with intranuclear inclusion, samoma body, and this is the histology of the same case. Metastatic breast carcinoma. So we can call it metastatic adenocarcinoma, but with the GATA, this is done on smear itself. GATA3 was positive on this, and this was metastatic breast carcinoma. And biopsy could follow up was better in the Sydney group. And even the flow cytometric follow was also better in the Sydney group. But this was the advantage by implementing the Sydney system we had in our study. And bone marrow correlation was also more in the Sydney. Statistical evaluation was done in 3 groups. Like in group A, only the malignant cells were taken as positive. Whereas in group B, we included even suspicious cases and malignant cases as positive cases. And in group C, we also included atypical category with the suspicious and malignant cases. So when we did that, there was no difference between the Sydney system and the conventional system. All had 100% sensitivity, specificity, positive predictive value, negative predictive value, and accuracy. This is very good in fact actually. Whereas when we included the suspicious cases, little bit different was there, but the difference between the two systems of reporting was not much. Whereas in the Sydney with the C group, when we included AUS cases also, the typical cases also, then this conventional system seems to be doing better. So we compared it with the other studies also. As compared to the other studies, there was a slight decrease in the number of the non-diagnostic rate in our study, and we also had lesser number of atypical cases and suspicious cases as compared to at least some of these 3 studies, Barua et al., Vigila et al., and Caputo et al. Studies. And when we compared the sensitivity, specificity, positive predictive value, negative predictive value with other studies in the literature, it was very much comparable. There was not much of difference among the various studies. So I have come to end of my presentation. To conclude, the benign lesions predominated in the conventional group, while the malignant ones were frequent, more frequent in the Sydney group. This was attributable to the COVID situation, during which we avoided performing euthanasia from the infected cases. Though there was a slight decrease in the non-diagnostic rate in the Sydney group, perhaps due to consistent use of the ROSE, no significant difference was noted in the sensitivity, specificity, and predictive values of euthanasia between the 2 groups. However, the Sydney system of reporting lymph node aspirates was streamlined in our institute with a more rigid and meticulous approach in sampling and interpretation, with the consistent use of ROSE, that is rapid on-site evaluation, and other relevant ancillary techniques like immunocytochemistry and flow cytometry. These are my references. Thank you for your patience here.